Currently, we have two TKIs that have been approved by the European regulatory agencies. It's the osimertinib for EGFR mutant tumors for 3 years, and also the alectinib for ALK-positive tumors for 2 years. This treatment is the standard of care after the surgery, and today also we know that both treatment strategies reduce the risk of progression, and also with osimertinib may improve the overall survival. It's true that both of these TKIs may induce some kind of gastrointestinal or skin toxicities, but are really well supported, and there is no detrimental effect in the quality of life for the patients. Today, I think that we don't have any current data that really support the peri-operative strategy with TKI. We have data supporting the adjuvant treatment with the TKIs, but there is no data supporting the peri-operative TKIs. I think that the results in the adjuvant setting are really impressive, both with osimertinib and alectinib. And for instance, I am not completely convincing that adding a neoadjuvant treatment with a TKI will really overcome the magnificent results with the adjuvant alone. So I should say that today it's not recommended to perform a peri-operative strategy with a TKI. I think that today, as I mentioned, there is no specific role for the peri-operative, but I think that in the adjuvant setting there are challenges that should be addressed. What is the optimal time treatment for these patients? 2 years, 3 years, 5 years? Also, if all of these patients who receive a surgery, if they should receive chemotherapy before of this TKI. Also, it's important to mention if how to can enlarge a proportion of patients that might have access to these TKIs, because the price of these drugs are really expensive. So I think that there are a lot of clinical challenges that should be addressed. Probably these questions will never be answered by the pharmaceutical industry, but it's important that the cooperative and the academic groups try to perform clinical trials to try to answer these clinical questions. I think that today it's important that we perform a genomic profile in patients with early stage non-small cell lung cancer before making any treatment decisions. It's really important that before or when we make the diagnosis to check if there is an EGFR or ALK alteration to try to decide if these patients should receive induction treatment with chemoimmunotherapy, but in case that any of both EGFR or ALK are positive, we should perform surgery plus or minus chemotherapy and then the TKI. It's really important to perform the genomic profile in all stages of the disease.